In this class, we're going to start talking about how to evaluate study quality and interpret data. I'll go over some of the types of bias that can impact epidemiologic studies, error, confounding, and interaction.
A hypothesis is your idea or a concept that you can test with research. When you have a prediction before beginning a research study, you form a hypothesis, and then you need to state your null hypothesis, which is if the difference that you hypothesize exists actually does not exist, if the two groups are the same. Note that failing to reject the null hypothesis is not the same as accepting the null hypothesis. Accepting the null hypothesis would require proving that no relationship exists, but that's usually not possible. So instead, epidemiologists fail to reject the null hypothesis if the data is insufficient to conclude that a relationship does exist. Random error is inaccuracy in data. Your textbook has a whole chapter on this. It's not systematically off in one direction, which differentiates random error from bias. It's impacted by both the scale measurements are taken on and the tools measurements are taken with. For example, we wouldn't ask research study staff to measure manual blood pressure down to the fraction of a millimeter mercury because you can't listen that precisely when taking a manual blood pressure. So blood pressures are always reported in whole numbers. But if for some reason you were doing a research study that needed more precise blood pressure measurements, you would need to use some sort of automated sphygmomanometer that could measure down to fractions of a millimeter mercury, because you can't do that with a manual cuff. Type 1 error, represented by alpha, is the probability of incorrectly rejecting the null hypothesis. So you think you found a relationship, you think you found a difference between the two groups, but there really isn't one. Type 1 error is analogous to false positive test results. You're concluding that you found something, but really there's nothing there. Type 2 error, represented by beta, is the probability of failing to reject the null hypothesis when you really should have. It's missing something that really was there, the equivalent of a false negative. And power is the inverse of type 2 error. It's 1 minus beta. The power of a test is the probability of rejecting the null hypothesis when it's false, thereby avoiding type 2 error. You can also think of it as the likelihood a study will detect a deviation from the null hypothesis, given that one exists. A p-value is the probability that if the study were repeated, assuming the null hypothesis is true, the result would be at least as extreme as the result that you got. In epidemiology and related fields, we use a p-value of less than or equal to 0.05 as the cutoff for being statistically significant. If you think back to the lecture on preventive health when I was talking about screening tests and how when working with a continuous variable like blood pressure, we have to make a cutoff in terms of what we will consider normal and what we will consider abnormal, and that cutoff point is somewhat arbitrary. A p-value of 0.05 is similarly a somewhat arbitrary cutoff point, but it's the universally accepted level in epidemiology and related fields. When studying a continuous variable like blood pressure, measured in a sample of the overall population, we would use a t-test to calculate a t-statistic, which is reported with a p-value and 95% confidence interval, which means if the study were repeated 100 times, going back through the whole process of re-sampling the population, the real value of what you're studying in the population would be included within your results 95 out of 100 times you repeated the study. P-values used in epidemiology are two-tailed because we can't presume to know the direction of the relationship we're studying. And p-values test not only the null hypothesis, but also the other assumptions being made in the analysis. P-values are determined by your sample size, the effect size, so if there's a really big difference between the two groups or if it's really small, and consistency of the data. Statistical significance means the difference between the treatment and control groups in a study was probably not due to chance. If a finding is not statistically significant, that means the difference between the groups being studied probably was due to chance. Either of these conclusions can be wrong, which is when type 1 and type 2 errors occur. Remember that when you're doing a survey or a randomized controlled trial, all the study designs we've talked about in this course, the outcome of interest is assessed in a sample of the larger population. And in most cases, the goal is to generalize the conclusions to the larger population your study participants are from. You can think about study results using the same 2x2 method we used to talk about screening test results. Again, on the top, we have the outcome of interest. With tests, we usually had disease, although it can be a good outcome instead. And just like before, the top of the 2x2 table is representing the truth in the general population. And we have study result rather than test result on the left. Just like with a screening test, a perfect test would label all the people who have the disease as positive and all the people who don't have the disease as negative. A perfect study would correctly find a true difference in the sample population if a difference exists in the general population, and would correctly identify when no difference exists when there's no difference in the general population. But just like with screening tests, research studies are also never perfect. Type 1 error happens when you find a difference when really no difference exists. It's a false positive. P-value is the type 1 error rate. The lower the p-value, the more sure we can be that the difference we see in the data is not due to chance, that there really is an underlying difference. Type 2 error occurs when a study finds no difference when one does actually exist, a false negative. The main determinant of type 2 error is sample size. The larger a study's sample size, the lower the risk of type 2 error. The convention is, when planning a study, to design it such that the type 2 error will be less than 20%. Beta, or type 2 error, determines the power of the study, the ability to detect a difference if one exists. The power of a study is the sensitivity because it's the ability of the study to detect a difference if there is one. In epidemiology, researchers design studies with a power of at least 80%. A study with a power of 90% means there's a 90% chance the study's results will provide an answer to the researcher's question versus a 10% chance they won't. You should be aware that the relationship between power and sample size isn't linear. Power does increase as sample size increases, but there's a point where the number of people you would need to enroll in a study would cause a small enough increase in the study's power that it wouldn't be worth it anymore. If the 2x2 table method is not helping you learn these concepts, don't sweat it, no big deal. The table isn't what's important here, it's just a tool to help you think through these concepts. But you shouldn't memorize the 2x2 table, and I want to caution you that I saw online that other people have also used the 2x2 table to explain these concepts, but most sources set up their 2x2 table differently, so the cells are in a different order, which could be really confusing. So if you do look at other sources to learn this, pay close attention to how they set up their 2x2 table, because it's likely not the same as how I did it. I make an effort to always set up my 2x2 tables the same to be consistent, but for whatever reason, a lot of sources switched the positive and negative on one side when talking about studies compared to talking about test results. In my table, the plus sign at the top left means a difference really is there in the general population, and the minus sign on the upper right means there's no difference in the real general population. Another way of thinking about this is type 1 error is the probability of rejecting the null hypothesis if the null hypothesis is true. And type 2 error is the probability of not rejecting the null hypothesis when the null hypothesis is false. Let's go through a basic example. If our hypothesis is that the new treatment works, then the null hypothesis would be that the new treatment doesn't work. In this example, if we make a type 1 error, we would conclude that the drug works, but it actually doesn't. And the consequence of a type 1 error in this example would be that maybe the FDA would approve the drug that doesn't actually work, and then people would take it. If we make a type 2 error in this example, we would conclude that the drug does not work, but it actually does. So a possible consequence would be the FDA doesn't approve a drug, so patients miss out on an effective treatment. Just like with selecting a screening test when there's a trade-off between sensitivity and specificity, increasing sensitivity often means decreasing specificity and accidentally labeling people as having the disease who really don't, false positives, while increasing specificity often means decreasing sensitivity, so you're not catching some people who actually have the disease, false negatives. The same is true of studies. The probability of making a type 1 error is set by the researchers when designing the study, usually at 5%, and there's a trade-off between type 1 error and type 2 error. The probability of making a type 2 error depends on the type 1 error rate, but also on the study's sample size, the size of the difference the study is trying to detect, and consistency of the data, as mentioned on the previous slide. Efficacy refers to how well the intervention works under ideal conditions. The study design typically used to assess efficacy is randomized controlled trials. It's a controlled, ideal setting. Effectiveness refers to how well the intervention works in the real world. So effectiveness is typically assessed with observational studies. Efficiency involves looking at the cost-benefit ratio of the intervention and can be assessed using either experimental or observational studies. In Lecture 4 on preventive health, I talked about the validity of screening tests. The validity of a research study refers to how well the results among the study participants represent the true findings among similar individuals outside the study in the general population. If a study has internal validity, the observed results represent the truth in the study population and are not due to bias or methodological errors. If a study has internal validity, the next question is whether the findings are generalizable to other populations. For clinical research, we'd be asking if the results apply to similar patients in different settings. If a study lacks internal validity, it's not safe to generalize the findings to other populations or settings, so that study also would not have external validity. Internal validity is a required precursor for external validity. If a sample is drawn from a subset of the general population that's not representative, the study may have internal validity but not external validity. The findings may not apply to other groups within the population. For example, if we studied the caloric needs of the UAA ski teams and our study was well designed, we may achieve internal validity so we can draw conclusions about the caloric needs of UAA ski team members. But this study likely would not be applicable to the general population of Anchorage. Most of us have caloric needs that don't come close to that of athletes on the ski teams because we're sitting for most of the day. This study would lack external validity, but it still might be worthwhile to conduct if our goal is specific to that population. For example, let's say several students have complained that the meal plan only allows for 1 plate of food per meal, but due to their level of exercise, they really need 3 plates of food. Such a study could be helpful to advocate for change at the school level to modify the meal plan policy for athletes who may need far more food than the average adult. A lack of external validity isn't always bad, it depends on your objectives. One more point about interpreting epidemiologic data. Statistical significance is not the equivalent of clinical significance. If a study with a very large sample size detects a statistically significant difference, it isn't necessarily clinically significant. P-values don't convey whether the study was free from bias or whether the study was well designed. So more interpretation is needed when reading epidemiologic data than simply seeing if the p-value was less than 0.05. Here's a practice question. Which of the following does a p-value tell us? The probability our hypothesis is true, the probability the null hypothesis is true, the probability of our data assuming our hypothesis is true, or the probability of our data assuming the null hypothesis is true. The p-value describes the probability of our data assuming the null hypothesis is true. It does not describe the probability of the null hypothesis being true given our data. The p-value also doesn't tell us the probability that the hypothesis is true or the probability that the null hypothesis is true. It's the likelihood that we would get a result at least as extreme as the result we got if the null hypothesis were true. Bias is a systematic error leading to an incorrect estimate of the effect of the exposure on the development of disease or outcome of interest. The observed effect will either be above or below the true value, depending on the nature of the systematic error. Bias is a result of defects in the design or execution of an epidemiological study. Bias can't be controlled in the analysis of a study, and it can't be eliminated by increasing the sample size. Bias is any systematic error in the design, conduct, or analysis of a study that results in a mistaken estimate of an exposure's effect on the risk of disease. Bias is often broken down into two broad types: selection bias and measurement bias, also known as information bias. I used the white star on this slide to indicate that selection bias is one of the main categories of bias. Volunteer bias, non-response bias, and exclusion bias are all types of selection bias. Selection bias occurs when there's a systematic difference between the people who are selected for a study and the people who were not selected for the study. Those differences in who gets selected lead to a non-representative sample, which in turn leads to distorted associations between the exposure and outcome. Selection bias is often thought of as a problem for randomized controlled trials, but it also can impact screening programs because people who come in for screening voluntarily are often different from the people who don't. As an example, if 100% of students rated the course a 5 out of 5 on the evaluation, we might conclude that everyone loves epidemiology. But if only 3 out of 200 students completed the voluntary course evaluation, that's not a representative sample. Those 3 students might be super enthusiastic about epidemiology, but the other 197 students might hate it and might have thought the course was terrible, but they didn't bother to fill out the evaluation because they really don't care. So our sample captured the 3 most enthusiastic students, but they aren't representative of the 200 total students that took the course. So by self-selecting to take the course evaluation, they introduced selection bias. Volunteer bias is also a problem both in randomized controlled trials and also screening programs and other types of studies where people volunteer to participate. They aren't randomly selected. As an example, people who come in voluntarily for a colonoscopy to screen for colon cancer are likely different from people who either delay screening or opt for a less invasive colon cancer screening like a FIT card or the new blood test, or who don't get screened for colon cancer. So if we were doing a study with a sample of only people who voluntarily came in for a colonoscopy, they might not be representative of the broader population. Maybe people come in for a colonoscopy rather than one of the less invasive alternative screening methods if they have a family history of colon cancer, or they come from an ethnic group with a high incidence of colon cancer, such as Alaska Natives. And those with a family history or people from a high-risk ethnic group have a higher risk of colon cancer, so their likelihood of the outcome of interest is different from that of the general population. Non-response bias occurs when response rates differ based on exposure or disease status. In general, people who are sick may be more eager to complete a questionnaire about their illness compared to people who are well. Let's say following a foodborne illness outbreak, a public health worker puts out a message on the local radio and calls people and emails people asking anyone who ate at a particular restaurant during a certain time frame to please call back so they can be interviewed about their specific exposures. People who are at home vomiting with diarrhea might be more likely to call in and let the public health worker know what they ate compared to people who are well and just going to work, going about their normal business. They wouldn't feel motivated to call the public health worker. That can lead to biased data where it looks like way more people are sick because the people who are well are likely to respond at a lower rate. The public health worker investigating the outbreak would overestimate the attack rate by systematically collecting more data from those who are ill than people who ate at the same restaurant but are well. Exclusion bias can be introduced when certain subgroups of people are intentionally excluded by the investigators. For example, if a researcher excludes frail elderly people from the study because they're worried that maybe they might be harmed by the new treatment, this would create a population with less frail elderly people, so it would be systematically different, and therefore the results may not be generalizable at the end because of this exclusion bias. Attrition bias is also known as dropout bias or loss to follow-up bias. It can occur if there's a differential loss of participants during the course of a study between the groups, leading to a non-representative sample. Attrition bias can distort the observed associations between the exposure and the outcome if the reason people are dropping out is related to the outcome of interest. For example, if the new treatment has bad side effects and it doesn't slow disease progression, and more people in the treatment group having the side effects and worsening disease drop out of the study, that could make the treatment and control groups look equal when they're really not. Lead time bias can occur if catching the disease earlier doesn't result in a longer survival. But if we diagnose people early, we have a longer observed survival. So it looks like we've done something, even if the people have the same longevity they would have had if we hadn't ever diagnosed them in the first place. For example, if we diagnose a man with prostate cancer and he lives 20 more years, but his cancer never would have spread, it never would have decreased his life expectancy, the screening program didn't actually do anything. It just looks like we did because we got 20 years observing this man following diagnosis. Information bias, the other main category of bias, is also known as measurement bias. It's caused by errors in the measurement or classification of an exposure, outcome, or confounding variables. It can result from inaccuracies in data collection methods, misclassification of study variables, or differential misclassification between study groups. Misclassification can be either differential or non-differential. Non-differential misclassification would happen if you used a poorly worded questionnaire for both cases and controls, so the data on both groups would not be accurate. Non-differential misclassification tends to wash out the difference. It brings the results closer to the null hypothesis. Differential misclassification would occur if the poorly worded questionnaire was only used on one group and not the other. It can cause a spurious association in either direction, leading researchers to find an effect even though there wasn't one. Another example is I used to have a really old blood pressure cuff, and it always read like 40 millimeters mercury high because it really needed to be calibrated, but I lost the tool for doing it, and the company went out of business, so I couldn't mail it back. If I somehow didn't realize that it was wildly off and kept using it, that wouldn't be random error, because everybody's blood pressure I took would be about 40 millimeters mercury high. It wouldn't vary in either direction. So if I was carrying out a study on blood pressure, and I used this poorly calibrated blood pressure cuff on both the cases and controls, that should lead to non-differential misclassification. But if I was assigned to check the blood pressure on the cases and someone else was assigned to do the control group, or vice versa, that would lead to differential misclassification. Recall bias is classically a problem for case control studies. It can occur anytime you're asking people to remember their exposures or health-related behaviors or anything that happened from the past that can't be objectively verified. For example, there was a study of women postpartum that was researching whether infections during pregnancy might be associated with congenital malformations, and the women in the control group who had a normal, healthy infant were much less likely to recall having an infection during pregnancy compared to the women who had an infant with birth defects, who were likely spending a lot more time trying to remember anything that happened during the pregnancy that might have been associated with this outcome. So that could make it look like there's an association that isn't really there. Overdiagnosis bias is a little bit similar to lead time bias, but it's based just on diagnosis versus having people in the community who aren't diagnosed, compared to lead time bias that's focused on duration of time observing the person following diagnosis. Clinicians in the US used to commonly do pap smears to screen for cervical cancer in teenagers and women under age 21 who were sexually active. But back before the HPV vaccines were available, 2/3 of sexually active young women used to get HPV. It was by far the most common sexually transmitted infection. And most young women who got HPV would never develop cervical cancer. Their immune system would clear the infection over time as they got older, And it would never really cause any problems for most women. That's why the United States Preventive Services Task Force changed the clinical guideline to start screening for cervical cancer at age 21 and not before then, because there was a lot of overdiagnosis going on. Teenage girls were getting diagnosed with cervical dysplasia, but it never would have turned into cancer. Cervical cancer is very rare among teenagers. Based on population data, now we know it's the women who are getting older, for example, who are over age 35 or so, who haven't cleared the infection. Those are the women we really need to be worried about and monitoring more closely. Observer bias, also known as interviewer bias, can happen if the presence or behavior of the investigator influences the study participant's response or the outcome. It can occur accidentally if the researcher is aware of the study participant's exposure status or outcome, which is why double blinding is ideal for research studies, where both the researcher and the study participants both don't know who's getting the treatment and who's getting the control. An example of observer bias when measuring blood pressure would be if you can't quite hear the systolic and you think, maybe it was about 120, because in your head you know that 120/80 is normal, so you might accidentally bias your reading based on what you think the result should be. If you're taking someone's blood pressure who seems otherwise healthy and you get a reading of, let's say, 80/70, you'd be like, what? There's something wrong there, and you'd repeat it, which clinically is the right thing to do, but in a research context, treating people differently based on readings could introduce bias. Publication bias happens when studies that find a difference or something interesting get published, and studies that don't find a difference don't get published. This is a real problem, especially with cohort studies. One research study looking into publication bias found that 31% of cohort studies for antidepressant drugs that were registered with the FDA were never published. And the literature included 91% positive studies, while the larger database of studies from the FDA, including both published and unpublished studies, contained 51% positive studies. The researchers requested the data from any grant recipients if they couldn't find the results from a study, and found that 13 out of 55 trials in that cohort, 23.6%, were never published. When they took all of these unpublished studies into account, the effect size of antidepressant medications was reduced by 25% when unpublished data was included in the pooled analysis with the published studies. Publication bias can even affect systematic reviews and meta-analyses, which are up at the top of the pyramid of levels of evidence, because usually if data isn't published, it isn't available to other researchers. So this can cause bias, often making treatments look like they had more of an effect, because the studies that find no effect are less likely to be published. That last example was based on an entry in the Catalog of Bias from University of Oxford, which is a good resource if you would like to read more about different types of bias. It's not specific to epidemiology, but I think the website is well done. I'll put the link on Blackboard under this lecture. Confounding occurs when an extraneous factor is associated with both the exposure and the outcome, leading to a distortion of the true relationship between them. Controlling for confounding variables is essential to minimize bias and strengthen the validity of causal influence in epidemiological research. Confounding is not a type of bias, and it can result in an association being either overestimated or underestimated. It's a big challenge in all observational studies because we can't control the environment that real people are living in outside of a randomized controlled trial environment. For something to be a confounder, it has to be associated with the exposure, it's a risk factor for the outcome, and it's not in the causal pathway between the exposure and the outcome. Going back to the cervical cancer example, HPV infection would not be a confounder when studying cervical cancer because it's in the causal pathway to the development of cervical cancer. Confounding can be mitigated both at the study design phase and at the analysis phase. At the design phase, randomization, matching cases and controls on known confounders, and restriction, meaning not enrolling people with a diagnosis likely to impact the outcome of interest, all can help mitigate confounding. At the analysis phase, stratification, performing matched analysis, and adjustment, like age adjustment we talked about in a previous lecture, can all be helpful. In 1981, McMahon and colleagues published an article in the New England Journal of Medicine which stated, "A strong association between coffee consumption and pancreatic cancer was evident in both sexes. After adjustment for cigarette smoking, the relative risk associated with drinking 2 cups of coffee per day was 1.8 with a 95% confidence interval of 1 to 3, and that with 3 or more cups of coffee per day was 2.7 with a 95% confidence interval of 1.6 to 4.7. This association should be evaluated with other data. If it reflects a causal relation between coffee drinking and pancreatic cancer, coffee use might account for a substantial proportion of the cases of this disease in the United States." Does coffee cause cancer? Smoking has been a well-known confounder when investigating the effects of coffee consumption using observational studies for many decades, because most people who smoke cigarettes also drink coffee. So these researchers in 1981 knew that smoking was a confounder they needed to adjust for, yet their data still showed a statistically significant increase in risk of cancer associated with coffee consumption. And they even thought they found a dose-response effect. Drinking more coffee was associated with a higher risk of cancer than drinking less coffee. So what happened here? A couple of things. You can see why, when looking at their data, they thought that they had really found something here. Based on their findings, I'd have a relative risk of pancreatic cancer of 3.1. But smoking is the main confounder here, in addition to the methodological problems with how they selected controls. First of all, they didn't separate out the people who were former smokers to control for past cigarette smoking adequately, which is really important when determining an individual's risk of developing cancer. People who were ill, such as those with chronic obstructive pulmonary disease after many decades of smoking cigarettes, may quit smoking due to the health effects of their smoking, so they would have been labeled former smokers, and that's a great step for the health of that individual, but their risk of cancer is still much higher than that of someone who never smoked cigarettes, if that person had smoked for 30 years and just quit 6 months ago, for example. This study also had a major design flaw in how controls were identified. The controls were inpatients at the same hospital as the cases, and they were patients who were admitted by the same gastroenterologists who were caring for the pancreatic cancer patients. So if you think about who would be under the care of a gastroenterologist, a lot of those patients may have stopped drinking coffee because they have gastric ulcers or other abdominal pain that's worsened by coffee consumption. So the people who said they don't drink coffee may have recently given up coffee due to gastrointestinal disease. So importantly, the controls in this study were not healthy people in the general population. Hypothetically, even if they had adequately controlled for past smoking and found a real association between coffee consumption and pancreatic cancer between these two groups, you certainly can't generalize in patients under the care of a gastroenterologist in whom pancreatic cancer was ruled out to the general population of coffee drinkers. The patients selected as controls in this study had an unusually low odds of the exposure coffee intake, which may have led to this spurious association between coffee intake and pancreatic cancer. A researcher observes that ice cream sales go hand in hand with shark attacks. When ice cream sales are high, shark attacks are high. When shark attacks are low, ice cream sales are low. Could ice cream cause shark attacks? In this example, heat waves are the confounding variable. There's no causal relationship between people buying ice cream and getting attacked by sharks. See how in this example, heat waves are not in the causal pathway? Heat waves cause both increases in ice cream sales and increases in shark attacks. Let's say the authors of this study failed to account for the heat index as a confounding variable. Assume increased ice cream sales are associated with heat waves, and heat waves also lead to more shark attacks, both due to altered animal behavior in warmer ocean waters and increased opportunity with all the people swimming on hot days. What impact would this failure to account for the effect of heat waves have on the odds ratio? I'll give you a second to think about it. In the 2x2 table, shark attacks that occur when ice cream sales are up is falsely inflated, while shark attacks that occur when ice cream sales are down is falsely deflated. Failing to account for heat waves would inflate our numerator when calculating the odds ratio relative to the truth and decrease our denominator relative to the truth. So we would overestimate the odds ratio. So if the authors failed to account for heat waves, the odds ratio would be greater than 1, but if they accounted for that confounding variable, it would bring down the odds ratio, likely to equal to 1. Another study found a low mortality from coronary heart disease among men who wear silk ties. What could be going on here that would explain the strong association found between wearing a silk tie and low mortality from coronary heart disease? In this case, socioeconomic status is the confounding variable. Rich men are more likely to wear silk ties, and they have access to healthcare and better food, and for many different reasons, wealthier men are less likely to die from coronary heart disease. Most diseases have multiple causes, so how do we figure out how much each cause contributes? And if we determine a factor causes disease, how can we tell if it's worse for some people than others? Effect modification can help answer this. Effect modification, also known as interaction, is not a type of bias. It needs to be accounted for in the analysis if you find it, and it should be included in the discussion of a study's report, but it's not always a bad thing. You just have to discuss it and report it. It occurs if the effect of two factors is greater than, if it's synergism, or less than, if it's antagonism, what would have been expected based on the effects of either factor alone. It can be on the additive scale or the multiplicative scale. Synergism increases disease risk more than what would be expected based on the effect of either variable alone. For example, people who smoke cigarettes are more susceptible to radon exposure. Antagonism decreases the risk of disease more than what would be expected based on either exposure alone. For example, people who consume vitamin C and iron reduce the rate of anemia better than either alone, because vitamin C doesn't independently prevent or treat anemia, but vitamin C does facilitate the absorption of iron, so taking both works better than iron alone. This isn't a perfect example, but antagonism could be another exposure like a vaccine, which, when combined with some other factor, protects the person even more from disease than with either of the factors alone. Epidemiologists look for possible interaction after they've concluded the association observed in their data is not due to confounding, meaning there is a causal relationship. The first step is to calculate what effect is expected from each variable in terms of risk of disease or another outcome of interest under study. Then we compare the expected risk to the observed risk in the study population to determine if there's effect modification. I know there's a lot of math in this explanation, but I want to reassure you, you will not have to calculate effect modification on the additive or multiplicative scale on the exam. I'm going to go through how, because my intention is for you to understand the concepts, not how to perform the calculations. The first step is to identify which scale, additive or multiplicative, the interaction may be occurring on. If it's unclear, you can always check both. These are incidence rates per 100,000 people in the population. On the top, we have when factor A is present and when factor A is absent. And on the left, we have when factor B is present and when factor B is absent. When both factors are absent, the rate is 3, the background risk. If you think back to the previous lecture when we talked about attributable risk, and I had the diagram showing the background risk that has to get subtracted out, this is the same concept. In order to isolate the increased risk of disease or the outcome of interest, attributable to each factor, we have to subtract the background risk. On the additive scale, to find the expected attributable risk of factor A, we subtract 3 from 9 to get 6. To find the expected attributable risk of factor B, we would subtract 3 from 12 to get 9. Then to find the expected value if there is no interaction on the additive scale, we add the attributable risk of factor A to the attributable risk of factor B to the background incidence rate, in this case to get 18. If the expected effect and the observed effect are the same, then the factors are acting independently. If the observed effect is greater than the expected effect, then there's a synergistic effect. And if the observed effect is less than the expected effect, then there's an antagonistic effect. In this example, the two factors together lead to an expected risk of 18 if there's no interaction occurring on the additive scale. Is there a synergistic interaction on the additive scale if we observed an incidence rate of 20 in our study population? Yes, because 20 is greater than the expected rate of 18. Is there a synergistic interaction on the additive scale if we observed an incidence rate of 15 in our study population? No, it's an antagonistic interaction on the additive scale because 15 is less than the expected rate of 18. To determine attributable risk on the additive scale, we can follow the same procedure. When both factors are absent, there's an attributable risk of 0, so we add the contribution of factor A to the contribution of factor B to get an expected attributable risk of 15. To assess for interaction on the multiplicative scale, we divide the effect of each factor alone by the background risk, then we multiply the relative risk of each factor by the background risk. In this case, we divide the incidence rate of 9 contributed by factor A by the background risk of 3 to get 3. Then we divide the incidence rate contributed by factor B of 12 by the background risk of 3 to get 4. Then we multiply 3 by 4 by 3 to get 36, which is our expected risk if no interaction is occurring on the multiplicative scale. Is there a synergistic interaction on the multiplicative scale if we observed an incidence rate of 40 in our study population? Yes, because 40 is greater than the expected rate of 36. Using the multiplicative model, we're going to look at relative risk rather than attributable risk like we did using the additive model. Remember that a relative risk of 1 means the exposure does not affect the risk of the disease. So in this case, if we multiply the risk of factor A by the background risk and the risk of factor B by the background risk and multiply them together, we get an expected risk when both factors are combined of 12. When we assess for interaction on the additive scale, we're looking at the attributable risk, and when we assess for interaction on the multiplicative scale, we're looking at relative risk. As an example, people who are intoxicated with alcohol have a higher rate of injury than that of the general population. People who are drunk fall down, they get injured in other ways, and similarly, people who race motorcycles have a higher rate of injury than the general population. And if you race motorcycles while drunk, it's very likely that the risk of injury would be increased even more than doing either of those activities alone. Let's say we want to figure out if the increased risk is occurring on the additive scale or the multiplicative scale. Our background risk of injury that we all have is 5, and the incidence rate of injury for people racing motorcycles is 20, so we subtract the background risk of 5 from 20 to get 15, which is the attributable risk of motorcycle racing. And people who are drunk have an injury incidence rate of 15, so we subtract the background risk of 5 from 15 to get an attributable risk of alcohol intoxication of 10. Then we add 5, 15, and 10 to determine that 30 is the expected risk if no interaction is occurring on the additive scale. Is there a synergistic interaction on the additive scale if we observed an incidence rate of 35 in our study population? Yes, because 35 is greater than the expected rate of 30. To calculate the expected effect modification on the multiplicative scale, we divide the rate of 20 contributed from motorcycle racing by the background risk of 5 to get 4, and we divide the risk of 15 by the background risk of 5 to get 3. Then we multiply the relative risk of motorcycle racing and the relative risk of alcohol intoxication and the background incidence rate, 5 by 4 by 3, to get 60, which is the expected risk if no interaction is occurring on the multiplicative scale. When analyzing the data from our study, we find an injury incidence rate of 64 for people racing motorcycles while intoxicated. Which of the following can we report that we found? Evidence of additive interaction, evidence of multiplicative interaction, or evidence of both additive and multiplicative interaction? Evidence of both, because 64 is greater than what we calculated as the expected risk using both the additive and multiplicative scales. To be an effect modifier, a variable should meet the criteria of being logically able to modify the effect of the exposure on the outcome of interest. It should not be on the causal pathway, and you should be able to find a statistically significant effect that there's evidence of effect modification occurring. You may not know if there is effect modification, that's why you're researching it, but it should be something that makes sense. It shouldn't be something illogical like ice cream causing shark attacks. The effect modifier should be a variable that you can reasonably hypothesize might be changing the effect of the exposure on the outcome of interest. Last class, I talked about how people living with HIV not only have higher rates of HPV infection, but the progression from cervical dysplasia to cervical cancer is much faster in people living with HIV compared to people with a normal immune system. The teal circles are the natural history of disease. Everyone who eventually gets cervical cancer progresses from getting infected with HPV, then having cervical dysplasia, then development of cancer. So HIV is not in the causal pathway. You certainly don't need to be HIV positive to get HPV infection and subsequently develop cervical cancer. But there's evidence of effect modification because HIV infection changes the disease progression. It leads to worse clinical outcomes for patients who have both compared to patients who only have HPV infection. Note that an effect modifier is different from a confounder because there is a real relationship there that's changing how the exposure affects the outcome, compared to a confounding variable, which is totally unrelated, but is also not in the causal pathway.
In summary, this class provided some examples to illustrate the process for critically appraising epidemiologic data and reports. We went through some of the types of bias that can be problematic in epidemiology and other factors to look for when reading literature and if designing your own study, including error, confounding, and interaction.